Good morning, everyone, and thank you for joining us for this morning's conversation with Dr. John Whyte, Chief Medical Officer of WebMD. My name is Chris King. I'm the Democratic Business Council of Northern Virginia President. And if you have been following us throughout these past many months during this pandemic, you know that we are trying to bring you the best and most up-to-date information regarding the pandemic and all of its many facets. So thank you for joining us this morning. We're going to give people a few more minutes to jump onto the call, but in the meantime, we'll get a few housekeeping items out of the way. If you are new to DemBiz and you're interested in learning more about us and becoming a member, which I certainly hope you will do, you can visit us at dembiz.org. That's DEMBIZ.org. And of course, you can also sign up to be a benefactor like our great Carlos Del Toro or a sponsor. So we encourage you to visit the site and become part of the DemBiz community. This webinar, just like the past webinars, will be very similar. I will ask some questions to Dr. Whyte, and then if you have a question, you could submit it via the Q&A box at the bottom of your screen. I'll be choosing those throughout the course of the next hour and relaying those to Dr. Whyte, and looking forward to a great discussion and a very timely one. I can't imagine a more timely guest than Dr. John Whyte at this moment. So without further ado, Dr. John Whyte is the Chief Medical Officer at WebMD. He was previously the Director of Stakeholder Engagement at the FDA's Center for Drug Evaluation and Research. He was also the Chief Medical Expert at Discovery Channel. He completed his internal medicine residency at Duke University Hospital Center and also has a master's in public health from Harvard. He is also continues to see patients as an internist, a board certified internist in the DC metro area. Dr. Whyte, I know you're very, very busy these days. Thank you so much for taking some time to join us this morning.
Absolutely, I'm delighted to be part of today's discussion. I'll point out, I've been in the DMV for 20 years. so I very much enjoy it here and happy to participate.
Fantastic. Well, as you know, most of our viewership is from the DMV, Northern Virginia. And so we're thrilled to have you here. So I want to get into the FDA's meeting yesterday, but before that, can you just provide a brief context for your role as Chief Medical Officer and what you view WebMD's role to be during this pandemic?
Sure. You know, at WebMD, we have 80 million unique visitors a month. 80 million. We also have Medscape, which is our physician portal, where we have 3 million members. So we have a huge reach. And what I've been focused on in the past few months is how do we provide the most accurate, the most relevant information to consumers as to how do they protect themselves, how do they stay informed during this pandemic? Because Chris, there's a lot of misinformation out there, not just about the vaccine, but about whether or not COVID, was created in a lab, whether it's, an attempt by Bill Gates to, track everyone. So our goal is, how do we get the best information out there? How do we help educate consumers without appearing like a medical school lecture, and really engaging them? And like today, giving people an opportunity to ask questions, no matter what it is. There's no dumb questions. And really being transparent and acknowledging when we don't know the answer. And that's the challenge. It's the novel coronavirus. It's new. There's a lot we don't know. That doesn't mean that we're hiding anything. That doesn't mean if we change recommendations like we did with masks, that's not a bad thing. That's a good thing. When scientists and leaders can look at more data and say, you know what, we need to make a new recommendation. So that's what I'm focused on at WebMD. Sure, we're covering a lot of other topics, as we always do: pregnancy, diet, cancer, diabetes. And in all those areas, we're trying to provide the best information, but it really matters right now on COVID. And I can tell you, the search on topics like anxiety are 7 times this year than they were last year at the same time. People are anxious, people are worried, and I want to get them the best information out there to help them manage during this very stressful time.
Well, and obviously this is a pandemic that is turning people's lives upside down in a variety of ways. Their home finances, their healthcare, their jobs, really top to bottom. And as you mentioned, millions of people will be consulting WebMD to find out your take and the company's take on what happened yesterday in particular, and the safety of this vaccine. So yesterday, the FDA's Vaccine Advisory Committee endorsed Pfizer's vaccine. This is part of the process where they are seeking an emergency use authorization. What was your takeaway from yesterday's meeting?
Sure, and I watched the committee meeting yesterday, as well as read the 53-page briefing document that the FDA prepared. And I encourage people to look at that. It's really a nice overview, and you don't have to be a statistician to understand it. The first couple pages are a nice executive summary. And what the committee ultimately decided was the benefits of the COVID-19 vaccine outweigh the risks. So that's how they phrased everything, which that was really a robust discussion. And the vote was 17-4. So it didn't mean everyone was, just fell in line, but really asked good questions, talking about how do we know that it's safe? How do we know that it's effective? And I will tell you, there was very good data about its safety and efficacy. And the difference about FDA than, say, the UK or Canada or Bahrain, where it's already been approved, is the FDA doesn't just take what the company submits. They actually get in the weeds and do their own analysis, look at the data directly and the reports, and come to their conclusions. So that's why I feel very confident that this is a safe and effective vaccine.
Okay, well, that is fantastic to hear. It sounds like their main questions at this point revolve around the unknowns about the long-term potential impacts of the vaccine. As you listen to it, how did you interpret those questions and concerns?
And I do want to announce that the Secretary of Health and Human Services, Alex Azar, said this morning that the FDA will authorize the vaccine. So we're waiting for that formal paperwork and notification. But what that means is that people will be able to start being vaccinated probably as early as January, as early as Monday, excuse me. In terms of the issues at the advisory panel, it wasn't as much about long-term safety because they looked at 60-day data. So we know if there is going to be serious adverse reactions or complications or something called a delayed immune response, meaning something that happens later, it's usually going to be in the first 60 days. So we feel pretty good that this is a safe vaccine. 60 days is a good amount of time. Where there was a lot of discussion was around 16 to 18-year-olds. And the reason why is a 16-year-old or 17-year-old the same physiologically, the way their body responds, as it is for a 25-year-old or a 30-year-old. And people debated that. There were probably less than 100 people between 16 to 18 in this trial of 44,000 people. So that was the scientific debate. Can you extrapolate? Can you generalize what we saw in an older population to a much younger population? Most people felt you could. But here's the good news, Chris. 16 to 18-year-olds in general are not going to be on any type of priority list. So we're going to be able to collect a lot more information about the vaccine. And as parents, because 16 to 18-year-olds are not going to be able to decide on their own to get vaccinated, the parents are going to have to decide. We'll have a lot more data by the time it comes around to that time.
Okay. And we talked a couple of weeks ago, and you had a great and very simple analogy about the importance of herd immunity and how it happens, why it's critical. Can you explain that?
Yeah. So here's the concept of herd immunity, right? So if we have a community, a group of people, and say 8 out of 10, 80% of those people are vaccinated, right? Or have developed the vaccine or developed the infection, have immunity and survived it. That's the key point. That's why we don't just let people get it and hope they survive. But they have antibodies. So when the virus is trying to come in, it's trying to look for an opening, right? 80, 90%, it's very hard to get an opening and get in and infect someone who hasn't already been infected or have antibodies. So that's a big challenge. And the virus only lasts for about 10 to 14 days. So it dies. But if only about 30% of people are immunized and have vaccination, right? So let's
Good
say
morning.
30% or so, now coronavirus can get in, right? Because there's lots of openings. That's why we need to have 70 to 80% of people immunized. So the virus can't get in and then it dies. It doesn't live forever. It's not around in the air, indefinitely. It's going to die. And you want to protect yourself and protect your community by not allowing it to get in. And that's what immunity and herd immunity does.
Okay. And as
I hope
always,
that was as good as last time.
Oh, we'll take it. We'll take it. How about that?
Sorry for the distraction. That's what happens when you're at home.
I think that's bound to happen. And if I had known he was going to be on, I would have put his name on the screen or something like that. So
he could give a good description too. He watches the news.
Yeah. So as I mentioned earlier, one of your prior responsibilities was as the Director of Stakeholder Engagement at the FDA's Center for Drug Evaluation and Research. So with your experience in trying to get people to buy into vaccines or the medical expertise that is out there, how do we convince people that this is safe? Given social media, given all the misinformation out there, how do we get this right?
Let's be honest, Chris, this has not been handled well from day one. I have never been in an environment where science is so politicized. In the past, people would say they don't understand science. Now, because of the current administration, people are saying they don't believe in science. And that's what's really frustrating. So here we had, pronouncements that the vaccine's going to be approved and it's going to be ready by election day, this and that. That doesn't inspire confidence in the public when they haven't even seen any information. I don't know if I would have called it from a communication perspective warp speed, something that we're putting in our bodies. So I think there have been so many missteps from the beginning because it sounded like it was just being rushed and it was going to be approved no matter what. Mm-hmm. And that caused people a lot of pause. And now we're trying to make up for that in being completely transparent. And in some ways, it's frustrating because here we've had enormous innovation in the life sciences sector, right? That we developed a new technology, mRNA. It actually existed for other therapies. Mm-hmm. And we streamlined a process that typically took years to months. But the reasons why that's the case is one is because the government guaranteed that it would pay for your research and pay for the vaccine. So even if it didn't work, it'd be bought and then just discarded. We don't usually have those incentives in drug development, right? And we also had a lot of virus around. Often what happens in vaccine development, you don't get around to developing it, and then the virus may be dissipating the community. In some ways, sadly, we were able to recruit a lot of people and see cases because there was so much virus around. So we should have explained why we were so successful in innovating, which is good to do, and how it's a success story. And instead, because of lack of leadership, conspiracy theories have been going on. I mean, you and I'm sure listeners have heard, how this was created in a lab, China. This is Bill Gates trying to inject a tracker and control all of us. I mean, this is what people are talking about. I got asked earlier today, is there, and I've seen it online, dye injected into the vaccine so then they can trace us through immunofluorescence. I mean, this is what people are really thinking and saying, and it's gonna not inspire confidence. And then when we start to hear about cases of severe allergic reactions, people that were sitting on the fence are going to be like, you know what, I'm going to wait this out. And when we go back to that concept of herd immunity, 30 to 40% not going to crush the virus. That's what we all want to do to return to normal. We have to crush the virus. I interviewed someone the other day that said, we have to treat COVID-19 like a house fire. That means you got to crush it all at once. You don't do one room at a time, that's not going to get rid of it. And that's my concern about the lack of leadership, which has created an opportunity for misinformation to flourish.
Well, certainly one of the most frustrating messages during this campaign was this idea that the COVID crisis would be over after Election Day, and that it was some big hoax. Hopefully, the people that bought into that will see that that was not the case, and may give a little more credence to the actual science and the messages coming out of the authorities who actually know what's going on.
Chris, do you remember? He actually said it was going to be gone by Easter. It's going to be
That's
beautiful, right? We were all going to go to church for Easter. Remember,
I forgot about that.
Do this. It was like, do this for 15 days. Remember that? And then 30 days. And then it was all going to be over by Easter. And here we are, Christmas, Hanukkah, New Year's, and we've limped along the whole way. This is not fake news. This is not made up. This is a pandemic that occurs once a century that sadly, we have not had leadership on a national level. The states have done as best as they can, but they need more resources to really manage this.
Right. Well, and it might be over by Easter, but it's going to be
Easter 2021.
Yeah.
Hopefully,
Yeah,
not
right.
2022. Yeah.
It sounds like the FDA has been a little more cautious for this very reason. They want people to understand that Great Britain has already started mass vaccinations. Canada approved Pfizer's vaccine this week. The FDA is slower to come around and more deliberate, it looks like. Is that going to pay dividends? Do you think that's registering with people?
I think it is registering. Convalescent plasma was not a good example for the FDA to have authorized, as the president seemed to have put undue pressure on them, and data was misrepresented. So it was a serious misstep in confidence. Let's be honest, the same for the CDC in terms of some of the political interference by political officials. So the FDA, and Dr. Hahn deserves a lot of credit, the commissioner, really had to be clear that we're going to make this decision based on the science, and there's not going to be politics involved. And they need to be very deliberate and very transparent in terms of their decision making. And I think we're seeing that.
Okay, good. I want to get to a couple of questions here. I'm gonna sort of blend a couple of questions from our good friend Lauren Hershey and also Deborah Steppel. Lauren is asking about the long-term effects of COVID, saying the successful immune system that beats off the COVID can then trigger long-term effects on different organs, brain, heart, liver, and chronic fatigue syndrome. 60 Minutes apparently touched on this recently. And then Deborah is asking about concerns about the vaccine causing infertility because of the genetic changes needed for an RNA vaccine. What are your thoughts on those?
So the first one relates to the issue of long haulers, persons that are not completely resolving the symptoms of COVID. So they're not infectious or contagious for many months, but they're suffering the long-term consequences to their respiratory system, to their nervous system, to the circulatory system in terms of developing clots, et cetera. So that's, one aspect of why it's so important to get vaccinated to protect yourself. The other element is this issue of cytokine storm. When patients become infected, their body mounts an immune response, but it overdoes it. And then it starts fighting normal aspects of the process. And that's, again, why we want to do it early on and get vaccinated or be treated very early. We've seen a lot of advancements in the areas of monoclonal antibodies, polyclonal antibodies. The president received them. Mr. Giuliani and Governor Christie received it. That could be something for people very early on. That's why it's important, because we're going to see people with long-term consequences of COVID, especially folks that are older and have underlying health conditions. In terms of the issue of infertility, the FDA has clearly delineated that in pregnant women, lactating women, we need more data to understand that. We haven't said that women should have a pregnancy test prior to vaccination, but the issue of infertility is something that we're going to learn more about. and we have some time to do that. I mean, the issue is always around risk versus benefit.
Mhm.
You know, what's your risk of getting COVID and having a serious reaction or dying from COVID versus, you know, some adverse reactions to the vaccine. This is a novel coronavirus. It's new. We're still learning stuff. And in the vaccine, we're going to continue to collect information. But right now, in issues of pregnant women, we're really pausing and collecting more information. We're always super sensitive when it comes to issues of pregnancy. And fertility, we're going to learn more.
Okay. And so is it too early to have learned anything from Great Britain? Canada hasn't really started administering
Yeah.
it yet, but have we learned Russia kind of put something on the ultra fast track? What have we
Yeah.
learned from overseas?
Russia's was called Sputnik. I'm not sure what we can learn from it. They have not been very transparent about the data. The UK, what we're learning, you know, one of their priority groups was over 80. So everyone there seems to be in the 90s when they're showing them on TV. And remember, people that are at that age, they're also more frail, their immune systems aren't as strong. And we're not hearing, other than those 2 cases of anaphylaxis, about complications from the vaccine. We're learning a lot about how they're managing the process logistically. So that helps all of us. It's still too early to learn more about what we call post-market surveillance. So technically it's not post-market because it's not fully approved, it's authorized, but we do have a very robust surveillance system for vaccines in the United States. So everyone that is going to be immunized, we're going to be able to know which vaccine, when there's multiple vaccines they got, when they got it, did they develop any adverse reactions or complications. So we're going to be pretty confident about its safety and effectiveness.
Okay. And it sounds like we've got 3 companies that are really at the forefront of the process as it stands right now. We've got Pfizer, we've got Moderna, and we've got AstraZeneca, each with different vaccines, it sounds like. And one thing that is kind of fascinating is the differences in how they need to be managed, transported, distributed, and presumably they might impact individuals in different ways. Pfizer's, for example, needs to be stored at minus 94 degrees Fahrenheit. That presents huge distribution and storage challenges. How do you think that will play out as all these come to market? We could probably spend an hour or 2 hours just talking about the logistics of distribution of the vaccines, but let's just start with the differences among the 3 and how they might come to market and be received.
And some of it's about timing. What's in hand? Do you wait until there's, you know, a vaccine that's less logistically challenging? So you're right. So the Pfizer vaccine is a messenger RNA vaccine. The way that works is that's a piece of genetic material that allows us to create that spike protein. It's called coronavirus because it has these crowns, corona, Latin from crown, and they're spiked. And that's the way it gets into our cells, gets into our lungs, gets into our blood vessels. So I give you the genetic code through this vaccine to create that spike protein. That's not going to give you coronavirus. Your body then develops an immune response to that spike protein. So then later, when you get or exposed to COVID-19, you're going to mount an immune response. So you're not going to get sick. That's the way the messenger RNA vaccine works. That's Pfizer, and that's Moderna. So Moderna has an FDA advisory panel meeting on December 17th, next week. I would expect they'll be authorized as well. That has a longer shelf life. It doesn't require as super cold temperature, but there's still some logistical issues. So both of those vaccines will be out and ready to go. AstraZeneca's vaccine is kind of the typical vaccine that we're used to. That's with an adenovirus. So it's similar to COVID-19, and I'm going to mount an immune response to the adenovirus. That doesn't require super cold temperatures. All of these right now are still 2 shots, so that's a challenge. People are going to have to come back, including AstraZeneca's. But here's where we're going to have a lot of debate. it's roughly 70% effective. And there's been some challenges with their data. They had an error where people got a half dose and they weren't supposed to. And they say that the response to the half dose is greater than the full dose. That doesn't make any sense. So that's going to require a lot more analysis. But the reason why people have been excited about the Astrazeneca vaccine, it doesn't require this complicated, freezing. That'll be especially relevant to the developing world where there will be issues of freezing temperatures. There's also the J&J vaccine, which is also an adenovirus. That trial is still underway. They just announced they're not going to recruit 60,000 people anymore. They're going to be more around 40,000. That also doesn't require these super cold temperatures, but they're not as far along. And then there's actually GSK and Sanofi, which probably won't come to the FDA until third quarter next year. So there are some options, but Chris, what's going to be the challenge that they're starting to look at is, what if you started off with Pfizer and Moderna, and then in your second dose, there's not enough Pfizer vaccine based on some decisions by the administration. Then would you get AstraZeneca's vaccine? They're not designed like that. And I'm also going to be honest, even in the state of Virginia, people aren't going to have the options to say, which should I choose? Should I choose AstraZeneca? Should I choose J&J? Do I get Pfizer, Moderna? You're going to get what's available in your local area. Right now it's a scarcity, even when they're producing it. There's not a lot around for people. So whether it's Pfizer or Moderna or whatever, that's what you're going to get. And sometimes that happens in the doctor's office with flu. There's FluMist, there's a quadrivalent, a trivalent. Everyone doesn't have all the different ones. So you get what's available. In some ways that makes it a little easier on people rather than trying to decide, which one is which. But right now, Pfizer and Moderna have higher efficacy than AstraZeneca. So it's going to be an interesting discussion. Would you choose something that's less effective because logistically it's easier to do? It could be different in the developing world, but we're going to be okay in Virginia, Maryland, and DC with having enough super cold freezers.
Okay. And so what is your interpretation of protection here? So how long somebody gets vaccinated, how long might they be protected for? And as the vaccine becomes more readily available down the road, if they've taken the AstraZeneca vaccine, can they later take a different one, or how does that work?
We don't think that's the case. That's not how the trials were designed to mix and match. They are thinking of doing a trial in the UK like that, even with Pfizer and Moderna, because technically they're not exactly the same vaccine. But I just want to do a step back and kind of describe the trial and maybe some terms to help people understand where this 95% comes in. So 44,000 people enrolled, half given placebo, a dummy vaccine that wasn't truly the mRNA vaccine, and half get the vaccine, and pretty well distributed in terms of sex, race, age, comorbid conditions. 162 cases of COVID in the control group, 8 cases in the vaccine group. So even with vaccination, that's why it's 95% effective, 8 people still got COVID. So not 100%. In terms of how long it's effective, that's something we're still going to need to study, because remember, we only have 60-day data after the second dose. What we're hoping and what we're thinking is that it's going to be years and not months, similar to other coronaviruses that we've seen, such as SARS and MERS. So that's what we're hopeful for. We don't know for sure. We're going to have to do more studies, look at something called neutralizing antibodies. But under the protocols that the FDA approved, these patients are going to be studied for 2 years post-vaccination. So we'll have more data. So I can't tell you whether it's going to be several months or several years. I'm hopeful that it's several years, but we're going to need more time to figure that out.
Okay.
We can't wait for 2 years to find out.
No,
how long
we can't.
it lasts.
We can't do that. All right, let's get to a few more questions here. Julie Strandley, you mentioned Virginia, Dr. Whyte. Fairfax County Public Schools is debating reopening, but the county chief medical officer does not recommend testing. Parents are concerned. How do we transfer the strict testing and compliance required at, say, William and Mary or UVA to our public schools? And also mentioning kind of risky behavior like travel sports and other outdoor
Yeah.
activities like that.
And I think what the school districts are trying to figure out, especially, Fairfax, where I'm in, is elementary school students, and this relates to the issue of 16 to 18, elementary school students are different than high school students and middle students in terms of risk. And the reason why that is, when you're younger, your respiratory tract is not as developed. We don't think you're able to expel virus as we do when we're older and can sing and shout. So even though there have been cases in elementary school students, it's very low. So how do we ensure enough protection for students, teachers, and staff? So, right, that's the challenge with the schools. We have these really young people, but then we have staff and teachers who are older, and some of them are at increased risk. So how do we protect teachers? And remember, vaccination is not for anyone under 16 right now.
Okay.
So testing, we really need to have a much more robust testing system, particularly for adults. And the president-elect has announced a robust testing program. The challenge with some of these rapid tests, and this is where there's a lot of debate, they're inaccurate. Sometimes they're 50% inaccurate because they were studied on people that were symptomatic. And we're now applying it to people as a mass screening type of strategy. So what do you do with these results? If it's negative, you don't really know if it's negative. If it's positive, you don't know for sure, but it at least tells you, hey, you better go home. We better do some contact tracing. We better do another test till we get more information.
Sure.
So I think we need to create a more robust testing system. We have to have it. And that's, it's a great question because it reminds us it's not one strategy that we can rely upon. So we can't even rely completely upon vaccination. It's about vaccination. It's about a much more robust testing system. Why are we waiting 5 days for results from PCR? That's absurd. We've got to cut it down even more to 1 day or so. That defeats the whole purpose of quarantining. And then still practicing these safeguards of hand washing, physical distancing. And I know everyone is trying really hard, particularly in the schools, but we have to think about strategies and we have to think about risk. And I know they're trying to do that. And we establish these guidelines about positivity of coronavirus in the community, about the number of new cases. But now they're also talking about, which I'm glad to see, about mitigating factors. And I'm glad to hear the president-elect is talking about in 100 days, the first 100 days, we got to get the schools open. And they need funding to do that. And that needs to be a priority. And, I'm confident that there's really going to be a comprehensive national strategy with funding to reopen the schools based on science. But Chris, we also have to acknowledge we always have risk in everything of our lives. And we can't say, well, we have to wait till it's 0 cases. I don't know if that's the case in the community. How do we weigh the risk versus benefit and the impact of our kids? I do remember, though, I want to say this real quickly, because I've been on some task force. People early on were saying, well, we're not going to open up the schools until we have a vaccine. But now with vaccine hesitancy, people don't say that. So right. We have to figure out a way. Let's be realistic. We have to get our schools open, and we have to do it safely that protects everyone, and give them some choice as we're doing for those folks that don't feel comfortable staying in. How do we make sure that they're still able to teach? And then how do we also make sure that our kids are getting good learning, recognizing the other aspects of lives that the school systems do for many children in our region?
Sure. What is your best guess as to how long we're going to have to wear a mask?
I think we're going to be wearing it at least for the first half of next year. Most of us, I'm used to it. If you are.
My son is almost 2 and he tries to put it on.
Yeah. I mean, most of us are used to it by now. And what I say is anything that we can do to help return to some sense of normalcy and community, we should all try. So even with vaccination, we're saying people should still wear a mask and practice the safeguards as we continue to collect more information. So let's be realistic. It's likely the first half of next year.
Okay. So and you don't see it like years down in the future. You don't see it through the end of 2021 into 2022.
I don't think it'll extend into 2022 if we're able to do these other aspects of wide-scale vaccination, continuing to develop therapeutics. The vaccine doesn't mutate in a way that makes it more dangerous. I'm hopeful about that.
Okay. You mentioned President-elect Biden. We are in
Mhm.
for a sea change at the top of the federal government. Question from Tom Greason, and this is appropriate because you've worked at the FDA and you have long experience in this. What is your take on President-elect Biden's proposed healthcare team? Javier Becerra as Secretary of
Mhm.
HHS and head of the CDC, and who is being talked about to head up CMS?
Yeah. And I know Tom, so thanks, Tom, for tuning in. I'm delighted to see that we have um, experts. I was going to say adults. I'm excited. We have experts
People who
back
believe
in
in
charge.
science, you mean?
Well, also experts that have been involved in healthcare and health policy. The California Attorney General has been involved in many healthcare issues for years
Mhm.
in terms of the CDC. Now, it's interesting. We have another expert in HIV. Dr. Redfield is an expert in HIV, but all of the picks have been talking about that they are going to speak truth and they're going to be experts. And we're not going to have this politicization of the CDC where we have people in the public affairs group at HHS reviewing scientific documents and editing them. Or we're not going to have people, just because you're a doctor doesn't mean that you're an expert in everything. So if you're a neuroradiologist, for example, that doesn't mean that you're an expert and should be giving advice on infection control. So I'm very optimistic about what Mr. Biden's proposed team can bring because they have long-standing expertise in health policy, in healthcare, and that's what we need rather than people that might just have a particular one area of interest. In terms of CMS, there's been some buzz around Mandy Cohen, who had worked at CMS before, who's been a Secretary of Health in North Carolina. The big pick that I think is also going to be interesting is who's going to lead the FDA. Is it going to be a former commissioner like Josh Sharfstein or Dr. Kessler? Josh was the principal deputy. Is it going to be someone new? Is Dr. Hahn going to be allowed to continue until a new commissioner is confirmed? That's not typically the case, but let's be honest, to put someone in as acting right now could be a challenge. But what I am confident about, Tom, as I'm sure you are, is that we're going to have adult leadership. We're going to have people that are experts in their field. And Mr. Biden has talked about that he is going to let the scientists guide his decision making. He's not going to make these pronouncements before anyone has looked at the data. So I'm happy to hear that we're going to have experts and scientists leading the department and leading important agencies.
Okay, good. Speaking of the federal government, one of the, we're a business group. We are a networking group of business professionals, and we're also progressives. And I think one of our common threads is that we recognize the importance of growth and public investment and infrastructure and not starving state and local and federal governments. What is your assessment of the past 3 years under the Trump administration with regard to funding government, having people in government roles, and the importance of the years and decades of built up knowledge and research that has helped enable a vaccine to come to fruition so quickly?
I think the challenge in the past 3 years has been, as many folks know, there have been lots of senior positions that were never filled. Other positions were held in acting capacities, which makes it very difficult for leadership and to create change. So that's been a big challenge. I mentioned to you, I was there during the transition. I remember where there was this crazy executive order that was for every new regulation, you need to remove 2 regulations. And for an agency that I was at FDA, where you make a lot of regulations, we actually had one person whose job was to look for old regulations that we could get rid of. And you think that's such a colossal
What are the qualifications for that job?
waste of time. That person had a previous job that I guess their plate wasn't full enough. So
I hope it didn't pay very much, because that seems pretty easy.
it was already someone who had a job that was distracted
okay.
with doing this other stuff. Like that's the craziness. But Chris, what I think is going to be the real challenge is we all have to recognize we're going to have tough choices, and there's going to be limited resources. So I expect Mr. Biden will make investment and want to make investment, and we'll see what happens with the Senate. It'll be less robust if the Republicans maintain control of the Senate. But even when I listen and I hear, well, we're going to provide funding to schools, that's what they need to reopen safely. We're going to invest in infrastructure, which we all need. But many states are suffering, including the area, in the loss of income and the loss of tax dollars and the tax base. So it's going to be some tough choices to make. But I think we're definitely going to see much more investment. I think we're going to see leadership positions filled on a full-time capacity and less of this revolving door. But we're going to have to be patient. We may have to modify, some big goals, but also make sure it's an environment where the business community can succeed. And there's always was the criticism earlier this year about how if Mr. Biden wins, the stock market's going to go down. We know there's actually been improvement in the stock market, so it's going to be a little rocky at first, but it's definitely in the right direction, and I'm optimistic. I think we all need to be hopeful right now on a variety of fronts. So I think the change will be very good for business as well.
Well, and I think business can thrive in a stable environment. Right now, the environment's not stable, so once it does stabilize, I think business can kind of take care of itself. But we got to get things straightened out first. There's no question about that. All right, one more question on this from Carrie Nixon. In the past few years in particular, we've seen a lack of coordination between FDA and CMS that has inhibited innovation in healthcare. Do you see that changing with the new administration, where these entities collaborate rather than operate in silos?
Yeah. And Carrie, it's nice to hear from you. So I didn't mention, I worked at CMS as well.
Okay.
I worked at FDA. And I'm going to be honest, I'm going to be fair. The lack of coordination has existed under Democratic administration and under Republican administrations. And I can tell you from the mindset of both, they're very insular. Also, just based on where physically they are. CMS says their regulatory standard is medically necessary and reasonable. That's how they look at it. And FDA's regulatory standard is safe and approval. And CMS will say, we used to use this analogy, FDA approval is a prerequisite. It puts something on the shelf. And CMS needs to be a prudent purchaser and decide what they're going to put in their cart. Just because it's on the shelf doesn't mean they're going to buy. And that's where the stress is. And the other challenge is that the information that sponsors provide to FDA is confidential information that can't be shared. That includes sharing it with other regulatory agencies, such as CMS, unless the sponsor allows you to do that. And don't assume that everyone allows you to do that upfront. So we may need some change in regulations to create, greater sense of collaboration, but we need it. But I'm going to be honest, it's very challenging because they view the regulatory mission as very distinct. And there's some good reason why that's the case. I think they've made improvement over the last few years. I mean, in the past, at CMS, you didn't even know what FDA was doing in terms of what was, on their plate, especially as it relates to devices with a different, approval and clearance process. But I also think it starts at the top. It starts with the president, it starts with the secretary, and then the commissioner and the administrator in terms of having that dialogue. It's often, a different sense of the staff too. FDA is dominated, right or wrong, by physicians and health professionals, and CMS is dominated often by policy analysts, people that started at Social Security. And there's a lot of career people, and that's the way it should be in both agencies, primarily career people, even in senior leadership. And sometimes it's hard to change a mindset, but the president-elect and whoever is the secretary is really going to help do that. So I'm going to be honest, I don't see too many changes early on. It's going to take a lot of work. People
Okay.
are still just going to have to recover from the whiplash
Right.
for the last 3 years.
Yeah. Okay. We're getting a couple more questions about the vaccine itself, a little more granular on these. One is from Tim Simmons. What effect, if any, does the vaccine have on the elderly and those on multiple medications?
So the elderly, defined as people over 65, and on medicines, I'm defining that as with multiple medical conditions, hypertension, diabetes, obesity. Those persons were in the study population and actually had a very good therapeutic response. Remember, those are the persons at greatest risk. Most of the deaths have occurred in the elderly, have occurred in people in nursing homes, have occurred in people with comorbid conditions. Not that it wasn't in younger people, but those were by far the exception. So it's the elderly with comorbid conditions, diabetes, high blood pressure, heart disease, that we need to be vaccinating. They're going to get the most benefit because they're the ones at greatest risk.
Okay. Science question for you from Catherine Tobin. Why does the Pfizer vaccine require to be kept so cold? What's the basic idea on the chemistry here?
It's a good chemistry question. And, Catherine, I was a chemistry major a long time ago. So I'm not completely sure why that is. It may relate to the suspension of the genetic material in these lipids. So I'm going to be honest, say it's transparency, say when you don't know. I don't know why it has to be super cold, but, I rely upon the scientists and the engineers who say for it to work, it has to be stored that way.
Okay. Let's talk about Virginia. Talked a little bit about it before. As I understand it, 4,200 deaths in the Commonwealth so far due to COVID. We are expected to receive plus or minus 480,000 doses. How will those be distributed? Who will get? We've talked about frontline workers. We've talked about nursing home workers and residents. How do you expect those doses to be deployed?
And I'm still waiting to hear more guidance from the state in terms of how they're distributing it. But something I often advise people when we're talking about a state like Virginia is it really matters what's happening in your community and by zip code. So I know we like to differentiate Northern Virginia from the rest of the state, but it actually is important to look to see what's happening in different regions of the state in terms of allocating resources to those regions. So clearly you want to devote more resources where there's more virus. And in Northern Virginia overall traditionally has been doing pretty good compared to the rest of the state. Not that it doesn't have an increased rate of infection and hospitalization just like everyone else. So what I haven't heard from the state, and different states are doing it different ways. So the CDC, in terms of its prioritization, has recommended health professionals who are involved in treating patients and then long-term care facilities. So some states are saying we're going to vaccinate both at the same time in terms of a rollout strategy. And others are saying, first, we're going to vaccinate health professionals. And then with what we have left, we will then vaccinate members of long-term care facilities and employees there. And part of that reason why is, in the first go around nationally, there's only 2.9 million doses in this first go around. There's going to be more. And the reason why is they're saying 2.9 million, but then they have to save another 2.9 million. So say I'm making it up, 10 million doses. They're going to split it in half, right? Because someone has to get a second dose, but then they're going to put another 10 to 20% in reserve. And the reason why that is what happens if some virus gets spoiled because of it was out too long? What if it was contaminated in the mixing? There's going to be some hiccups along the way. So we're going to wait and find out, because even as we talk about healthcare workers, people are doing it different ways. Some people are saying we're just going to immunize emergency rooms and hospitals first, and not doctors' offices. That'll come later. So and waiting for guidance from the state. And Maryland, Virginia, and the district all have to decide exactly how they're going to distribute vaccination, and who's going to be first and who's going to be second, even in that 1A category.
Well, even the definition of healthcare worker is subject to debate, because you take a dentist, for example, who is operating directly in somebody's mouth
Yep.
Day in and day out. Hey, bud, where do they fit into this? And where are they prioritized?
So typically how they're defining it is frontline workers. So that is those persons who are involved in the care of patients with COVID. So clearly that's emergency rooms, that's people in the ICU. It may not be everyone in a hospital setting, given the scarce resources, but you're right. We have to hear more about dentists, about optometrists, and others, because what we're trying to do, remember, is we're trying to get people to come back and get the care that they've been foregoing, including cancer screening. Well, the health professionals are at risk there too. So we need to vaccinate them. We're going to find out more in the next few days. But I also want to caution people who are listening, there's going to be hiccups. What I'm hopeful is this is not the challenges and the mix-ups that we've had with testing rollout, with PPE rollout. That's where leadership and experience really come into play. People who have done this and know how to manage it well is what we need. But I do feel in the states, they're going to quickly be announcing exactly how they're going to roll out. But no matter what, it's healthcare workers and that are first line, care persons, as well as long-term care facilities and those that work there that are going to be first, which are not going to be the majority of people listening today.
Okay. What can you tell us about non-vaccine treatments for COVID at this point?
So this is also a story of innovation as well. If you think about it, in February and March, we had nothing. And remember, everyone was saying hydroxychloroquine and all that. And we do know that, and that's why we do controlled trials.
Or at least one person was saying that.
that it doesn't work. But here's the sad point, Chris. I recently posted on Twitter how specialists, the number of prescriptions by specialists that typically don't prescribe hydroxychloroquine were up dramatically because people were asking their doctor to have it as a prevention. That's why we do trials. No, it doesn't work. But we've had some encouraging data. It's been plus minus on remdesivir for those people that are in the hospital. We've seen the benefit for many patients of steroids, of monoclonal and polyclonal antibodies early on. We're going to continue to see more data around that. So that's the other nice aspect in terms of, even though we're seeing deaths, the rate of increase is not what it was before. It's still increasing, but not the rate, because we do have more therapeutics than we did in February. And that's also a big component of Operation Warp Speed that we don't hear about. We only hear about the vaccines. There's like 200 candidates in terms of drug trials that are being evaluated for treatment of COVID.
Okay, well, that's all good. Hopefully those come around sooner than later. It'd be, I think they would help a lot. I want to step back and ask you a personal question, just because you become a medical professional and you devote your life to this, and something like this comes around. What is it like to be in the profession at this moment? And in some ways, is it kind of the culmination of your whole career kind of coming to a head? What's it like being somebody in your position right now?
I think a lot of my colleagues, to be honest, are just overwhelmed and they're frustrated. So here they're seeing people that present with a serious disease, and many people aren't taking this seriously. And it's needlessly putting people at risk. It's putting health professionals at risk. It's not just the doctors, the nurses, the people that are at the front desk. And it doesn't need to be this way. So I think there's enormous frustration, as opposed to some other health conditions. There's still a lot of bad outcomes that occur. We've been learning along the way, even in terms of ventilator settings. I mean, I think my colleagues really are, heroes in terms of they're putting their lives at risk every day in terms of being on the front line. But I think many of my colleagues are frustrated and they're anxious. They want to see an end to this just like everyone else. And I think there's light at the end of the tunnel. And I hope people are willing to seriously consider vaccination, weighing those risks and benefits. And I wish more people would follow the guidelines that we've been trying to get people to do. You know, this is a business call. The way we reopen businesses, the way we reopen schools is to control the virus in the community. I mean, they're completely related. So if we truly want to open up businesses and open up the schools, let's bring the viral load down in the community. And it's a respiratory virus. You catch the virus from other people. It's not like it happens randomly. It doesn't.
Right.
It's not like you're at home all by yourself and you're quarantined and somehow you get it. That's not how it occurs. It occurs through contact with other people. So we need to minimize the amount of contact that we have with other people, still practice the safeguards. And if we manage that, we're going to have a more complete opening. Otherwise, we're just limping along the way. You know, for no one wants to do that for another 9 months.
No, certainly not. And flu season is upon us as well. How do you, what's your advice to people about differentiating between flu and COVID when it comes to symptoms?
Yeah. Well, first of all, everyone should have already had the flu shot. And if they haven't, they should get it today. I've had my flu shot. My wife has had her flu shot. We all need to have the flu shot. This is not the year to be debating whether or not you should get the flu shot. And the reason why is you don't want to get the flu and COVID either at the same time or weeks apart. It's a double whammy that you may not recover from. The symptoms of coronavirus early on can be similar: fever, headache, cough. But with COVID, you usually do have shortness of breath. We do know from studying people that loss of smell is common. If you have coffee every morning and you can't smell the coffee in the morning, that's a red flag. You might need to be tested, especially if you have other symptoms. So in the first couple of days, they can be similar. And that's why, you know, you want to talk to your doctor. You can get a rapid flu test. We usually do that early on to rule out flu. But the same safeguards that we're doing to protect ourselves from COVID actually are going to protect people from influenza as well, in terms of mask wearing, hand washing, physical distancing, and just like with influenza, vaccination.
Okay, that's a good point. Didn't think of it that way. We are coming up on an hour. Just got a couple more questions.
Sure.
One is a vaccine question that I meant to get to earlier, but I didn't, from John Cartmill. If there are mutations, will we need a COVID vaccine every year?
Hey, John, guess what? There's already been mutations in the virus that we've seen, but they haven't been mutations that are serious enough to change its virulence, to change how it impacts the body. So it actually has been mutating, and that's what's expected, but not in a way that would change how our body responds to it. If that does happen to be the case, and I don't think it will be, you're right. We may have to have a virus like influenza where there's a different strand every year, and we need to figure that out. The preliminary data doesn't lead us to believe that any mutations will change how the virus responds, how antibodies are going to, be created and respond to the virus.
Okay. All right. Last question is from me, and hopefully I'm speaking for more than just myself here, but one real life challenge with this pandemic has been not being able to travel, not being able to see relatives. My parents live in California. Would love to travel to Europe or Asia. What is your best guess as to when those will be safe?
Yeah, and everything is a risk calculus of a risk versus benefit. The issue with air travel, and there's been a lot of studies on this, is not actually getting on the plane itself because the filtration system goes from up from down, but it's all the other aspects of air travel: getting a taxi, parking in a garage, using the bathroom next to the gate, being exposed to other people. Everyone doesn't wear a mask correctly. Let's be honest, people have it below their nose all the time. You're just putting yourself at increased risk. And then, in terms of international travel, we have a lot of quarantines. We can't go even if we wanted to. But I think there's a desire to, again, return to this sense of normalcy. And I think vaccination is going to provide that pathway. The issue will be if we don't get to wide scale vaccination, we're going to continue to limp along. So I'm hopeful by late spring, when we have, an ability to have immunized basically everyone who wants to be immunized, and hopefully it's 70, 80%, we'll be able to have much more extensive travel than we've been able to these, past several months. It's all about managing risk, and how do we do it in a way that keeps people safe while trying to have some sense of normalcy. But we're not going to have that, old normal that we're used to for many more months, and it's going to be a new normal. And including travel is a key component, but we're really going to have to crush the virus, as I've talked about. So the virus just goes away on its own. That's not usually the best strategy. So we can have good therapeutics and continue to improve upon that, and a robust vaccination program. I'm hopeful, certainly by summer, that we'll be able to resume, travel in a way that we were used to.
And so you have confidence that the rest of the world, or in particular the rest of the developed world, will move along at the same pace that we do, if not maybe a little faster?
I think in general, the rest of the world tends to be more accepting of vaccination than the United States. There's often difference in terms of how they view community and how they view state authority as well. So we'll see, but I bet there's more robust acceptance of vaccination in Europe and the rest of the world than there'll be in the United States. Maybe not. Hopefully, I'm wrong, but I don't hear as many of the issues about vaccine hesitancy in the UK, and I know in other areas of Europe they're very eager to get vaccination, and there's some historical differences between the cultures.
Okay. All right. Well, Dr. John Whyte, Chief Medical Officer at WebMD, it has been a fascinating conversation. We could spend hours, I'm sure, and I'm sure you have many hours ahead of you today, talking with more outlets and more groups. So I really appreciate you taking the time to fill us in on these and help us benefit from your experience.
Thanks for having me. I appreciate it, the opportunity.
All right. And thanks to everyone who tuned in. Stay tuned for more DemBiz webinars coming up right around the bend. Have a great Friday and a great weekend. Take care.